Varkarolis, Chapter 12, Anxiety and Anxiety Disorders. Key terms and concepts: acute stress disorder, agoraphobia, anti-anxiety drugs, anxiety, defense mechanisms, fear, generalized anxiety disorder, or GAD, mild anxiety, moderate anxiety, panic disorder, PD, post-traumatic stress disorder, PTSD, severe anxiety, social phobia, specific phobias. Here we go. For most people, anxiety is an everyday part of life. I got really anxious when I couldn't find a parking space just before my final exam. I think I would have done better without that worry. For some people, however, anxiety-related symptoms become severely debilitating and interfere with normal functioning. Today I got so worried I couldn't find a parking space before the final exam, I stayed home. Or imagine being so incapacitated by anxiety, you live in dread of germs to the point where hand washing has become the focal point of your day. Consider repeatedly feeling the immediate terror of emotionally relieving a horrific event in your life, such as hydroplaning on the expressway and finding yourself facing oncoming traffic in the opposite lanes. You would likely refuse to drive when it rains. In this chapter, we will examine the concept of anxiety, defenses against anxiety, and an overview of anxiety disorders and their treatment. Anxiety. Anxiety is a universal human experience and is the most basic of emotions. It can be defined as a feeling of apprehension, uneasiness, uncertainty, or dread resulting from a real or perceived threat. Fear is a reaction to a specific danger, whereas anxiety is a vague sense of dread related to an unspecified or unknown danger. However, the body physiologically reacts in similar ways to both anxiety and fear. Another important distinction between anxiety and fear is that anxiety affects us at a deeper level. It invades the central core of the personality and erodes feelings of self-esteem and personal worth. Dysfunctional behavior is often a defense against anxiety. When behavior is recognized as dysfunctional, nurses can initiate interventions to reduce anxiety. As anxiety decreases, dysfunctional behavior will frequently decrease, and vice versa. Normal anxiety is a healthy reaction necessary for survival. It provides the energy needed to carry out the tasks involved in living and striving toward goals. Anxiety motivates people to make and survive change. It prompts constructive behaviors, such as studying for an examination, being on time for a job interview, preparing for a presentation, and working toward a promotion. An understanding of the levels and defense patterns used in response to anxiety is basic to psychiatric mental health nursing care. This understanding is essential for assessing and planning interventions to lower a patient's level of anxiety, as well as one's own, effectively. With practice, you will become skilled at identifying levels of anxiety, understanding the defenses used to alleviate anxiety, and evaluating the possible stressors that contribute to increased levels of anxiety. Levels of anxiety. As discussed in Chapter 2, Hildegard Peplau had a profound role in shaping the specialty of psychiatric mental health nursing. She identified anxiety as one of the most important concepts and developed an anxiety model that consists of 4 levels: mild, moderate, severe, and panic. The boundaries between these levels are not distinct, and the behaviors and characteristics of individuals experiencing anxiety can and often do overlap. Identification of the specific level of anxiety is essential because interventions are based on the degree of patient's anxiety. Mild anxiety. Mild anxiety, which occurs in the normal experience of everyday living, allows an individual to perceive reality in sharp focus. A person experiencing a mild level of anxiety sees, hears, and grasps more information and problem-solving. A person experiencing a mild level of anxiety sees, hears, and grasps more information, and problem-solving becomes more effective. Physical symptoms may include slight discomfort, restlessness, irritability, or mild tension-relieving behaviors, e.g. nail biting, foot or finger tapping, fidgeting. Moderate anxiety. As anxiety increases, the perceptual field narrows, and some details are excluded from observation. The person experiencing moderate anxiety sees, hears, and grasps less information and may demonstrate selective inattention, in which only certain things in the environment are seen or heard, unless they are pointed out. The ability to think clearly is hampered, but learning and problem solving can still take place, although not at an optimal level. Physical symptoms include tension, pounding heart, increased pulse and respiratory rate, perspiration, and mild somatic symptoms, gastric discomfort, headache, urinary urgency. Voice tremors and shaking may be noticed. Mild or moderate anxiety levels can be constructive, because anxiety may be a signal that something in the person's life needs attention or is dangerous. See the case study and nursing care plan for moderate anxiety on the Evolve website. Severe anxiety. The perceptual field of a person experiencing severe anxiety is greatly reduced. A person with severe anxiety may focus on one particular detail or many scattered details and have difficulty noticing what is going on in the environment, even when it is pointed out by another. Learning and problem solving are not possible at this level, and the person may be dazed and confused. Behavior is automatic and aimed at reducing or relieving anxiety. Somatic symptoms, headache, nausea, dizziness, insomnia, often increase. Trembling and a pounding heart are common, and the person may experience hyperventilation and a sense of impending doom or dread. See case study nursing care plan 12.1 on pages 239 to 241. Panic. Panic is the most extreme level of anxiety and results in markedly disturbed behavior. Someone in a state of panic is unable to process what is going on in the environment and may lose touch with reality. The behavior that results may be manifested as pacing, running, shouting, screaming, or withdrawal. Hallucinations or false sensory perceptions, e.g. seeing people or objects not really there, may be experienced. Physical behavior may become erratic, uncoordinated, and impulsive. Automatic behaviors are used to reduce and relieve anxiety, although such efforts may be ineffective. Acute pain may lead to exhaustion. Review Table 12.1, which distinguishes among the levels of anxiety in regard to their 1. Effect on perceptual field, 2. Effects on ability to learn, and 3. Physical and other defining characteristics. Table 12.1, Levels of anxiety. Mild. May have heightened perceptual field, is alert and can see, hear, and grasp what is happening in the environment, can identify things that are disturbing and are producing anxiety. Moderate. Has narrow perceptual field, grasps less of what is going on, can attend to more if pointed out by another, selective inattention. Severe. Has greatly reduced perceptual field, focuses on details or one specific detail, attention scattered, completely absorbed with self, may not be able to attend to events in environment even when pointed out by others. In panic, unable to focus on the environment, experiences the utmost state of terror and emotional paralysis, feels he or she ceases to exist. In panic, may have hallucinations or delusions that take place of reality. In severe panic levels of anxiety, the environment is blocked out. It is as if these events are not occurring. Ability to learn, for mild, would be able to work effectively toward a goal and exam alternatives. Mild and moderate levels of anxiety can alert the person that something is wrong and can stimulate appropriate action. Moderate ability to learn would be able to solve problems but not at optimal ability, benefits from guidance of others. Severe ability to learn, unable to see connections between events or details, has distorted perceptions. And panic ability to learn, may be mute or have extreme psychomotor agitation, leads to exhaustion, shows disorganized irrational reasoning. Severe panic levels prevent problem solving and discovery of effective solutions. Unproductive relief behaviors are called into play, thus perpetuating a vicious cycle. Physical or other characteristics. For mild would be slight discomfort, attention-seeking behaviors, restlessness, irritability or impatience, mild tension-relieving behaviors, foot tapping, chewing, lip chewing, fidgeting, moderate physical characteristics, voice tremors, change in voice pitch, difficulty concentrating, shakiness, repetitive questioning, somatic complaints, urinary frequency and urgency, headache, backache, insomnia. Severe feelings of dread, ineffective functioning, confusion, purposeless activity, sense of impending doom, more intense somatic complaints, dizziness, nausea, headache, sleeplessness, hyperventilation, tachycardia, withdrawal, loud and rapid speech, threats and demands, panic, experience of terror, immobility or severe hyperactivity or flight, dilated pupils, unintelligible communication or inability to speak, severe shakiness, sleeplessness, severe withdrawal, hallucinations or delusions, likely out of touch with reality. And defenses against anxiety. Sigmund Freud and his daughter Anna Freud outlined most of the defense mechanisms we recognize today. Defense mechanisms are automatic coping styles that protect people from anxiety and maintain self-image by blocking feelings, conflicts, and memories. Although they operate all the time, defense mechanisms are not always apparent to the individual using them. Adaptive use of defense mechanisms helps people lower anxiety to achieve goals in acceptable ways. Maladaptive use of defense mechanisms occurs when one or several are used in excess, particularly in overuse of immature defenses. Figure 12.1. Figure 12.1 operationally defines anxiety and shows how defenses come into play. With the exception of sublimation and altruism, which are always healthy coping mechanisms, all defense mechanisms can be used in both healthy and unhealthy ways. Most people use a variety of defense mechanisms, but not always at the same level. Keep in mind that evaluating whether the use of defense mechanisms is adaptive or maladaptive is determined for the most part by their frequency, intensity, and duration of use. Table 12.2 describes defense mechanisms and their adaptive and maladaptive uses. Table 12.2, adaptive and maladaptive uses of defense mechanisms. Defense mechanism. Compensation is used to make up for perceived deficiencies and cover up shortcomings related to these deficiencies to protect the conscious mind and from recognizing them. The adaptive use of compensation is a shorter than average man becomes assertively verbal and excels in business. A maladaptive use of compensation would be an individual drinks alcohol when self-esteem is low to temporarily diffuse discomfort. Conversion. Conversion is the unconscious transformation of anxiety into a physical symptom with no organic cause. Often the symptom functions to gain attention or as an excuse. An adaptive version would be a student is unable to take a final examination because of a terrible headache. A maladaptive would be a man becomes blind after seeing his wife flirt with other men. Whoa, that would be bad. Denial. Denial involves escaping unpleasant, anxiety-causing thoughts, feelings, wishes, or needs by ignoring their existence. Adaptive would be a man reacts to news of the death of a loved one by saying, "No, I don't believe you. The doctor said he was fine." And then a maladaptive would be a woman whose husband died 3 years earlier, still keeps his clothes in the closet and talks about him in the present tense. Displacement. Displacement is the transference of emotions associated with a particular person, object, or situation to another non-threatening person, object, or situation. Adaptive, it would be a patient criticizes a nurse after his family fails to visit. Maladaptive would be a child who is unable to acknowledge fear of his father, becomes fearful of animals. Okay. Disassociation is a disruption in the usual integrated functions of consciousness, memory, identity, or perception of the environment. It may result in a separation between feeling and thought. This can also manifest itself in compartmentalizing uncomfortable or unpleasant aspects of oneself. Adaptive version would be an art student is able to mentally separate herself from the noisy environment as she becomes absorbed in her work. Maladaptive would be as the result of an abusive childhood and the need to separate from its realities, a woman finds herself perpetually in a world where she feels disconnected from reality. Identification. Identification is attributing to oneself the characteristics of another person or a group. This may be done consciously or unconsciously. Adaptive would be an 8-year-old girl dresses up like her teacher and puts together a pretend classroom for her friends. And a maladaptive would be a young boy thinks a neighborhood pimp with money and drugs is someone to look up to. Intellectualization is a process in which events are analyzed based on remote, cold facts and without passion, rather than incorporating feeling and emotion into processing. Adapt would be despite the fact that a man has lost his farm to a tornado, he analyzes his options and leads his child to safety. Maladaptive would be a man responds to the death of his wife by focusing on the details of daycare and operating the household rather than processing the grief with his children. Introjection is the process by which the outside world is incorporated or absorbed into a person's view of the self. Adaptive would be after a wife's death, a man has transient complaints of chest pains and difficulty breathing, the symptoms his wife had before she died. Maladaptive would be a young child whose parents were overcritical and belittling, grows up thinking that she is no good. She has taken on her parents' evaluation of her as part of her self-image. Projection. Projection refers to the unconscious rejection of emotionally unacceptable features and attributing them to other people, objects, or situations. You can remember this defense through the childhood retort of, "What you say is what you are." A man who is adaptive would be a man who is unconsciously attracted to other women, teases his wife about flirting. Maladaptive would be a woman who has repressed an attraction toward other women, refuses to socialize. She fears another woman will make homosexual advances toward her. Rationalization. Rationalization consists of justifying illogical or unreasonable ideas, actions, or feelings by developing acceptable explanations that satisfy the teller as well as the listener. Adaptive would be an employee says, "I didn't get the raise because the boss doesn't like me." Maladaptive would be a man who thinks his son was fathered by another man, excuses his malicious treatment of the boy by saying he is lazy and disobedient, when that is not the case. Reaction formation is when unacceptable feelings or behaviors are controlled and kept out of awareness by developing the opposite behavior or emotion. Adaptive, a recovering alcoholic, constantly preaches about the evils of drink. Maladaptive, a woman who has an unconscious hostility towards her daughter is unprotective and hovers over her to protect her from harm, interfering with her normal growth and development. Regression. Regression is reverting to an earlier, more primitive and childlike pattern of behavior that may or may not have been previously exhibited. Adaptive would be a 4-year-old boy with a new baby brother starts sucking his thumb and wanting a bottle. Maladaptive, a man who loses a promotion starts complaining to others, hands in sloppy work, misses appointments, and comes in late for meetings. That was regression. This is repression now. Repression is a first-line psychological defense against anxiety. It is the temporary or long-term exclusion of unpleasant or unwanted experiences, emotions, or ideas from conscious awareness. This happens at an unconscious level. A man forgets his wife's birthday after a marital fight, and that would be the adaptive. Maladaptive would be a woman is unable to enjoy sex after having pushed out of awareness a traumatic sexual incident from childhood. Splitting. Splitting is the inability to integrate the positive and negative qualities of oneself or others into a cohesive image. Aspects of the self and of others tend to alternate between opposite poles. For example, either good, loving, worthy, and nurturing, or bad, hateful, destructive, rejecting, and worthless. So adaptive would be a toddler views her parents as superhuman and wants to be like them. Maladaptive would be a 26-year-old woman has difficulty maintaining close relationships, despite the fact that she can initially find many positive qualities about new acquaintances. Eventually she becomes disillusioned when they turn out to be flawed. Sublimation is an unconscious process of substituting mature, constructive, and socially acceptable activity for immature, destructive, and unacceptable impulses. Often these impulses are sexual or aggressive. So adaptive would be a woman who is angry with her boss writes a short story about a heroic woman. Maladaptive would be the use of sublimation is always constructive? Oh, well, it says it's always constructive. It's unconscious process of substituting mature, constructive. Oh, okay, so you're substituting mature for immature. Okay. Suppression. Suppression is the conscious denial of a disturbing situation or feeling. For example, Jessica has been studying for the state board examination for a week solid. She says, I won't worry about paying my rent until after my exam tomorrow. Adaptive would be a businessman who is preparing to make an important speech. Later in the day is told by his wife that morning that she wants a divorce. Although visibly upset, he puts the incident aside until after his speech, when he can give the matter his total concentration. Maladaptive would be a woman who feels a lump in her breast shortly after leaving for a 3-week vacation, puts the information in the back of her mind until after returning from vacation. Undoing. Undoing is most commonly seen in children. It is when a person makes up for an act or communication. Adapt would be after flirting with her male secretary. A woman brings her husband tickets to a concert he wants to see. And maladaptive is a man with rigid moralistic beliefs and repressed sexuality is driven to wash his hands to gain composure when around attractive women. Anxiety disorders. Individuals with anxiety disorders use rigid, repetitive, and ineffective behaviors to try to control their anxiety. The common element of such disorders is that those affected experience a degree of anxiety so high that it interferes with personal, occupational, or social functioning. Recent studies also suggest that the presence of chronic anxiety disorders may increase the rate of cardiovascular system-related deaths. Anxiety disorders tend to be persistent and often disabling. Chapter 11 offers a more complete description of the debilitating effects of chronic stress and resultant anxiety. Clinical picture. The term anxiety disorder refers to a number of disorders including panic disorders, phobias, obsessive-compulsive disorder, generalized anxiety disorder, post-traumatic stress disorder, acute stress disorder, substance-induced anxiety disorder, anxiety due to medical conditions, anxiety disorder not otherwise specified. Figure 12.2 presents the Diagnostic and Statistical Manual of Mental Disorders, 4th edition. Panic disorders. Panic attacks are the key feature of panic disorder, or PD. The following vignette gives an example of a patient with signs and symptoms of a panic attack. The vignette. Sophia, a 30-year-old pharmacist, began to experience tension, irritability, and sleep disturbances after her mother's death from heart disease. On several occasions, Sophia has awakened, gasping for breath, her heart pounds, and she feels a tight sensation like a band around her chest. Her pulse typically increases to more than 110 beats per minute, and she experiences dizziness. She fears she is going to die. On these occasions, Sophia telephones a friend to come over. The friend typically finds Sophia wringing her hands, moaning, and appearing totally disorganized. In each instance, the friend takes Sophia to the emergency department, where Sophia remains overnight for observation and tests. All diagnostic tests results are normal. Because the physician finds no apparent organic basis for the episodes, she suggests they are likely panic attacks. A panic attack is the sudden onset of extreme apprehension or fear, usually associated with feelings of impending doom. The feelings of terror present during a panic attack are so severe that normal function is suspended, the perceptual field is severely limited, and misinterpretation of reality may occur. Severe personality disorganization is evident. People experiencing panic attacks may believe they are losing their minds or having a heart attack. The attacks are often accompanied by highly uncomfortable physical symptoms such as palpitations, chest pain, breathing difficulties, nausea, and feelings of choking, chills, and hot flashes. Typically, panic attacks come out of the blue, i.e. suddenly and not necessarily in response to stress, are extremely intense, last a matter of minutes, and then subside. Table 12.3 outlines a generic nursing care plan for PD. Figure 12.2, diagnostic criteria for various anxiety disorders. It's a big chart with panic disorder, phobias, obsessive compulsive disorder, and generalized anxiety disorder. Panic disorder for agoraphobia. Panic disorder for agoraphobia is a combination of panic attack symptoms and agoraphobia. Agoraphobia is intense, excessive anxiety or fear about being in places or situations from which escape might be difficult or embarrassing, or in which help might not be available if a panic attack occurred. The feared places are avoided in an effort to control anxiety. The examples of situations that are commonly avoided by patients with agoraphobia are being alone outside, being alone at home, traveling in a car, bus, or airplane, being on a bridge, and riding in an elevator. Avoidance behaviors can be debilitating and life-constricting. Consider the effect on a father whose agoraphobia renders him unable to leave home and prevents him from seeing his child's high school graduation, or the businesswoman whose avoidance of flying prevents her from attending distant business conferences. See Figure 12.2 for DSM-4 criteria for panic disorders. Generic plan for panic disorders. This is Table 12.3. Nursing diagnosis. Anxiety as evidenced by sudden onset of fear of impending doom or dying, increased pulse and respirations, shortness of breath, possible chest pain, dizziness, abdominal distress, panic attacks. Outcome criteria. Panic attacks will become less intense and time between episodes will lengthen so that patient can function comfortably at the usual level. Short-term goal. Patient's anxiety will decrease to moderate by a certain date. 2. Patient will gain mastery over panic episodes by whenever. Intervention. 1A. If hyperventilation occurs, instruct patient to take slow, deep breaths. Breathing with the patient may be helpful. Keep expectations minimal and simple. Help patient connect feelings before attack with onset of attack. Help patient connect feelings before attack with onset of attack. Okay. What were you thinking about just before the attack? You could say. Or you could say, can you identify what you were feeling just before the attack? Help the patient recognize symptoms as resulting from anxiety, not from catastrophic physical problems. Examples. Explain physical symptoms of anxiety. Discuss the fact that anxiety causes sensations similar to those of physical events, such as a heart attack. Identify effective therapies for panic episodes. Teach the patient abdominal breathing to be immediately used when anxiety is detected. Teach patient to use positive self-talk such as, I can control my anxiety. Teach patient and family about any medication ordered for patient's panic attacks. Rationale. Oh, well, we missed that part. You can read that on your own. Here's another vignette. Andrew is a 28-year-old man who suffers from panic attacks from agoraphobia. He once lived a very active life, often participating in thrill-seeking activities like bungee jumping and skydiving. Andrew's father, who had severe cardiovascular disease, died 2 years previously on his way to work. Since that time, Andrew has become increasingly fearful of the outdoors. He has gradually stopped leaving the family home because he experiences panic attacks, fearing he will die if he leaves home. Simple agoraphobia. Agoraphobia without a history of panic disorder, i.e. accompanied by panic attacks, occurs only rarely and early in the patient's history. Over time, agoraphobia with panic attacks usually develops. Phobias. A phobia is a persistent, irrational fear of a specific object, activity, or situation that leads to a desire for avoidance or actual avoidance of the object, activity, or situation. Specific phobias are characterized by the experience of high levels of anxiety or fear in response to specific objects or situations, such as dogs, spiders, heights, storms, water, blood, closed spaces, tunnels, and bridges. Specific phobias are common and usually do not cause much difficulty because people can contrive to avoid the feared object. Clinical names for common phobias are given in Table 12.4. Clinical names for common phobias, Table 12.4. Clinical name feared. Okay, so acrophobia is heights. Agoraphobia, open spaces. Astrophobia, electrical storms. Claustrophobia, closed spaces. Glossophobia, talking. Hematophobia, blood. Hydrophobia, water. Monophobia, being alone. Mysophobia, germs or dirt. Nyctophobia, darkness. Pyrophobia, fire. Xenophobia, strangers. Zoophobia, animals. Here's another vignette. Danielle developed a morbid fear of elevators after being trapped in one for 3 hours during a power outage. As his fear and anxiety intensified, it became necessary for him to use only stairs or escalators. Danielle even became anxious if he had to enter closets or small storage rooms. He had developed claustrophobia, or a fear of closed spaces. Social phobia, also called social anxiety disorder, or SAD, is characterized by severe anxiety or fear provoked by exposure to a social or performance situation, e.g. fear of saying something that sounds foolish in public, not being able to answer questions in a classroom, eating in public, performing on stage. Fear of public speaking is the most common social phobia. Characteristically, phobic individuals experience overwhelming and crippling anxiety when faced with the object or situation provoking the phobia. Phobic people go to great lengths to avoid the feared object or situation. A phobic person may not be able to think about or visualize the object or situation without becoming severely anxious. The life of a phobic person becomes more restricted as activities are given up so the public object can be avoided. All too frequently, complications ensue when people try to decrease anxiety through self-medication with alcohol or drugs. See Figure 12.2. Vignette. William, a 22-year-old musical theater major, develops a fear of performing on stage. He suffers severe anxiety attacks whenever he is scheduled to appear in a student production. Recently, he has become severely anxious when faced with giving classroom readings or singing solo in music class. He's thinking about changing his major. Obsessive compulsive disorder, OCD. Obsessions are defined as thoughts, impulses, or images that persist and recur so that they cannot be dismissed from the mind. Obsessions often seem senseless to the individual who experiences them, ego dystonic, and their presence causes severe anxiety. Compulsions are ritualistic behaviors an individual feels driven to perform in an attempt to reduce anxiety. Performing the compulsive act temporarily reduces high levels of anxiety. Primary gain is achieved by compulsive rituals, but because the relief is only temporary, the compulsive act must be repeated again and again. Although obsessions and compulsions can't exist independently of each other. They most often occur together. Examples of common obsessions and compulsions are given in Table 12.5. Obsessive compulsive behavior exists along a continuum. Normal individuals may experience mildly obsessive compulsive behavior. For example, nearly everyone has had the experience of having a tune run persistently through their mind, despite attempts to push it away. Many people have nagging doubts as to whether a door is locked or the stove is turned off. These doubts require the person to go back to check the door or stove. Minor compulsions such as touching a lucky charm, knocking on wood, making the sign of the cross upon hearing disturbing news are not harmful to the individual. Mild compulsions about timelessness, orderliness, and reliability are valued traits in U.S. society. At the pathological end of the continuum are obsessive-compulsive symptoms that typically involve issues of sexuality, violence, contamination, illness, or death. Pathological obsessions or compulsions cause marked distress to individuals, who often feel humiliation and shame regarding these behaviors. The rituals are time-consuming and interfere with normal routines, social activities, and relationships with others. Severe OCD consumes so much of the individual's mental processes that the performance of cognitive tasks may be impaired. See Figure 2.12.2. Generalized anxiety disorder, or GAD, is characterized by excessive anxiety or worry about numerous things, lasting for 6 months or longer. The individual with GAD also displays many of the following symptoms. Table 12.5, common obsessions and compulsions. Well, first I'm going to, the GAD symptoms are restlessness, fatigue, poor concentration, irritability, tension, and sleep disturbance. Okay, so Table 12.5, common obsessions and compulsions. Type of obsession, doubt, need to check. Doubt, need to check. Example, did I turn off the stove? Repeatedly intrudes on the thinking of a woman who had recently gone from being a housewife to holding a secretarial position. Accompanying compulsion, checks to see if appliance is turned off. Returning home several times each workday. Okay, the type of obsession, sexual imagery or ideation. And a young woman has the recurrent thought, pat his buttocks when in the presence of a man. The accompanying compulsion would be avoids the presence of men if possible. If with men, excuses self to wash hands every 10 to 15 minutes. Type of obsession, need for order. Example, everything must be in place is the recurrent thought. Compulsion would be arranges and rearranges items. Type of obsession, violence. A man repeatedly has the thought, I should kill her, when he sees a blonde woman. Compulsion abruptly turns head away from women and squints eyes to try to avoid seeing blondes. Type of obsession, germs or dirt. Example, a woman ruminates, everything is contaminated. A compulsion would be avoids touching all objects, scrubs hands if forced to touch any objects. So back to GAD. It's restlessness, fatigue, poor concentration, irritability, tension, sleep disturbance. The individual's anxiety is out of proportion to the true impact of the event or situation about which the person is worried. Examples of worries typical in GAD are inadequacy in interpersonal relationships, job responsibilities, finances, health of family members, household chores, and lateness for appointments. Sleep disturbance is common because the individual worries about the day's events and real or imagined reviews past problems, and anticipates future difficulties. Decision-making is difficult, owing to poor concentration and dread of making a mistake. Vignette. Angie is a 49-year-old legal secretary. She comes to the clinic complaining of feeling so anxious I could jump out of my skin. She is shaking and diaphoretic. She has dilated pupils, an elevated pulse, and a quivering voice. She tells the nurse, It was probably foolish to come here. Nobody understands me. Angie's only daughter is expecting her first child. Although the pregnancy is going well, Angie worries that something is wrong with the baby. What if it's premature? What if it's deformed? Angie describes herself as tense and irritable. She has difficulty initiating sleep and cannot concentrate at her job. She worries about making mistakes at home, about being fired from her position, and about the financial problems that could result. She often says, "I just can't cope." Her daughter has begun calling several times a day to reassure her that all is well, and the pregnancy and other matters. The daughter has also begun shopping and house cleaning for Angie to help her get some rest. Post-traumatic stress disorder. Post-traumatic stress disorder, PTSD, is characterized by persistent re-experiencing of a highly traumatic event that involved actual or threatened death or serious injury to self or others, to which the individual responded with intense fear, helplessness, or horror. PTSD may occur after any traumatic event that is outside the range of the usual experience. Examples are military combat, detention as a prisoner of war, natural disasters such as floods, tornadoes, and earthquakes, human disasters such as plane and train accidents, crime-related events such as bombing, assault, mugging, rape, and being taken hostage, or diagnosis of a life-threatening illness. PTSD symptoms often begin within 3 months after the trauma, but a delay of months or years is not uncommon. Figure 12.3 presents this criteria. The major features of PTSD are persistent re-experiencing of the trauma through recurrent intrusive recollections of the event, dreams about the event, and flashbacks, dissociative experiences during which the event is relived and the person behaves as though he or she is experiencing the event at the time. Persistent avoidance of stimuli associated with the trauma, causing the individual to avoid talking about the event or avoid activities, people, or places that arouse memories of the trauma. Table 12.6, generic care plan for generalized anxiety disorder. Nursing diagnosis, ineffective coping related to persistent anxiety, fatigue, difficulty concentrating. Outcome criteria, patient will maintain role performance. Short-term goal, patient will state that immediate distress is relieved by end of session. Interventions for this will be stay with patient, speak slowly and calmly, use short, simple sentences. Rationale conveys acceptance and ability to give help, conveys calm and promotes security, and promotes comprehension. Other interventions would be assure patient that you are in control and can assist him or her. That counters feelings of loss of control that accompanies severe anxiety, and also give brief directions. This reduces indecision, conveys belief that patient can respond in a healthy manner, and also decrease excessive stimuli, provide quiet environment. This reduces need to focus on diverse stimuli, promotes ability to concentrate. Also, after assessing level of anxiety, administer appropriate dose of anxiolytic agent if warranted. This will reduce anxiety and allows patient to use coping skills. Also, monitor and control your own feelings. This anxiety is transmissible. Displays a negative emotion can cause patient anxiety. Another short-term goal would be patient will be able to identify source of anxiety by a certain date. So to do this, you want to encourage patient in interventions. You want to encourage patient to discuss preceding events. This promotes future change through identification of stressors. You want to link patient's behavior to feelings. This promotes self-awareness. You want to teach cognitive therapy principles. Anxiety is the result of dysfunctional appraisal of a situation. Anxiety is the result of automatic thinking. This provides a basis for behavioral change. You want to ask questions that clarify and dispute illogical thinking, such as, what evidence do you have? Explain the logic in that. Are you basing that conclusion on fact or feeling? What's the worst thing that could happen? This helps promote accurate cognition. You can have patient give an alternative interpretation. This broadens perspective, helps patient think in a new way about a problem or symptom. Another goal, patient will identify strengths and coping skills by a certain date. And the interventions here provides awareness of self as individual with some ability to cope. This for this you're identifying what has or identify what has provided relief in the past. You could also have patient-led assessment of strengths. This will increase self-acceptance. You can have them reframe situation in ways that are positive. This provides a new perspective and converts distorted thinking. Okay, and well, back to PTSD. These are more major features of PTSD. Sorry, we had a big chart in the middle there. I'm just getting through it. So this is more PTSD features. Persistent numbering of general responsiveness as evidenced by the individual's feelings detached or estranged from others, feeling empty inside or feeling turned off to others. Persistent symptoms of increased arousal as evidenced by irritability, difficulty sleeping, difficulty concentrating, hypervigilance, or exaggerated startle response. Difficulty with interpersonal, social, or occupational relationships nearly always accompanies PTSD, and trust is a common issue of concern. Children and spousal abuse may be associated with hypervigilance and irritability, and chemical abuse may begin as an attempt to self-medicate to relieve anxiety. Excuse me, sorry. Acute stress disorder. Acute stress disorder occurs within 1 month after exposure to a highly traumatic event, such as those listed in this section on PTSD. To be diagnosed with acute stress disorder, the individual must display at least 3 dissociative symptoms either during or after the traumatic event, including a subjective sense of numbing, detachment, or absence of emotional responsiveness. A reduction in awareness of surroundings, derealization or a sense of unreality relating to the environment, depersonalization, it's an experience of a sense of unreality or self-estrangement, or dissociative amnesia, loss of memory. By definition, acute stress disorder resolves within 4 weeks. Vignette. Olivia, a 22-year-old college student, is sexually assaulted by a family friend. In the emergency department, she describes feeling detached from her body and being unaware of her surroundings during the assault, as though it took place in a vacuum. She describes virtually no effect, i.e., she does not cry, or she displays virtually no effect. She does not cry or appear anxious, angry, or sad. Olivia finds it difficult to concentrate on the examiner's questions. 3 days later, Olivia still feels as though her mind is detached from her body. She reports having difficulty sleeping, not being able to concentrate, and startling whenever anyone touches her. When she sees the nurse 4 weeks after the event, Olivia expresses feelings of anger and sadness over the assault. It displays the ability to concentrate and states that she no longer feels as though her mind and body are detached. She reports being able to sleep better and not being so jittery. Substance-induced anxiety disorder. Substance-induced anxiety disorder is characterized by symptoms of anxiety, panic attacks, obsessions, and compulsions that develop with the use of a substance or within a month of stopping the use of a substance. For diagnosis of substance-induced anxiety disorder, evidence of the use of the psychoactive substance, e.g. alcohol, cocaine, heroin, hallucinogens, must be obtained through the history, physical examination, or laboratory findings. Anxiety due to medical conditions. In anxiety due to medical condition, the individual's symptoms of anxiety are a direct physiological result of a medical condition, such as hyperthyroidism, pulmonary embolism, or cardiac dysrhythmias. To determine whether the anxiety symptoms are due to the medical condition, a careful and comprehensive assessment of multiple factors is necessary. Once again, evidence must be present in the history, physical examination, or lab findings for a diagnosis of anxiety due to medical condition. Refer to Table 12.7 for a list of medical disorders that may contribute to anxiety symptoms. Anxiety disorder not otherwise specified. specified. Anxiety disorder not otherwise specified is a diagnosis used for disorders in which anxiety or phobic avoidance predominates, but the symptoms do not meet full diagnostic criteria for a specific anxiety disorder. Epidemiology. Anxiety disorders are the most common form of psychiatric disorders in the United States. They affect up to 40 million adults, or about 18% of the population aged 18 and older. Nearly 3/4 of those with an anxiety disorder will have their final episode by age 21 and a half. People with anxiety disorders frequently seek health care services for relief of physical symptoms at a cost of approximately $22 billion a year. Women are affected more frequently than men. Table 12.8 lists the one-year prevalence rates, those who are affected within any given year, for specific anxiety disorders in the United States. Clinicians and researchers have clearly shown that anxiety disorders frequently co-occur with psychiatric problems. This is comorbidity. Okay, first I'm going to go to Table 12.7, common medical causes of anxiety. Respiratory, chronic COPD, pulmonary embolism, asthma, hypoxia, pulmonary edema, cardiovascular angina pectoris, arrhythmias, congestive heart failure, hypertension, hypotension, mitral valve prolapse, endocrine would be hyperthyroidism, hypoglycemia, pheochromocytoma, carcinoid syndrome, hypercortisolism, and neurological will be delirium, central tremor, complex partial seizures, Parkinson's disease, akathisia, autoneurological disorders, loss of hearing, post-concussion syndrome, metabolic be hypercalcemia, hyperkalemia, hyponatremia, and porphyria. Okay. Comorbidity. Clinicians and researchers have clearly shown that anxiety disorders frequently co-occur with other psychiatric problems. Several studies suggest that other psychiatric disorders coexist about 90% of the time in people with generalized anxiety or panic disorder, 84% in those with agoraphobia, and 70% in those with PTSD. Anxiety disorders are comorbid with major depression at a rate of 60%. In this type of comorbidity, anxiety symptoms tend to happen before depression symptoms. In fact, treatments for both disorders are similar. This similarity leads to speculation that genetically, anxiety and depression may be two sides of the same coin and not distinct disorders. Etiology. There is no longer any doubt that biological factors predispose some individuals to pathological anxiety states, e.g. phobias, panic attacks. By the same token, traumatic life events, psychosocial factors, and sociocultural factors are also etiologically significant. Biological factors, genetic. Numerous studies substantiate that anxiety disorders tend to cluster in families. Twin studies demonstrate the existence of a genetic component to both panic disorder and obsessive-compulsive disorder. First-degree biological relatives of those with OCD or phobias have a higher frequency of these disorders than exists in the general population. Nearly half of people with panic disorders have a relative who is also affected. Even for post-traumatic stress disorder and generalized anxiety disorder, there is evidence of inherited components. Neurobiological. Certain anatomic pathways, the limbic system, provide the transmission structure for the electrical impulses that occur when anxiety-related responses are sent or received. Neurons release chemicals, neurotransmitters, that convey these messages. The neurochemicals that regulate anxiety include epinephrine, norepinephrine, dopamine, serotonin, and GABA. There, there are various theories regarding the causes of anxiety disorders. One is the GABA benzodiazepine theory. Benzodiazepine receptors are linked to a receptor that inhibits the activity of neurotransmitter GABA. The release of GABA slows neural transmission, which has a calming effect. Binding of benzodiazepine medications to benzodiazepine receptors facilitates the action of GABA. This theory proposes that abnormalities of the benzodiazepine receptors may lead to unregulated anxiety levels. Studies suggest that the stress response of the hypothalamus pituitary adrenal system is abnormal in patients with PTSD. Repeated trauma or stress not only alters the release of neurotransmitters, but also changes the anatomy of the brain. Neuroimaging has demonstrated that the size of the right hippocampus is significantly reduced in combat veterans who suffer PTSD. Psychological theories. Psychodynamic theories about the development of anxiety disorders center on the idea that unconscious childhood conflicts are the basis for symptom development. Sigmund Freud suggested that anxiety results from the threatened breakthrough of repressed ideas or emotions from the unconscious into the unconscious. The unconscious into the conscious. To consciousness? From the unconscious into consciousness. Freud also suggested that ego defense mechanisms are used by the individual to keep anxiety at manageable levels. The use of defense mechanisms results in behavior that is not wholly adaptive because of its rigidity and repetitive nature. Harry Stack Sullivan believed that anxiety is linked to the emotional distress caused when early needs go unmet or disapproval is experienced, interpersonal theory. He also suggested that anxiety is contagious, being transmitted to the infant from the mother or caregiver. Thus, the anxiety experienced early in life becomes the prototype for anxiety experienced when unpleasant events occur in life, later in life. Evidence-based practice, teenage pregnancy, and the trauma of giving birth. Problem. Despite the fact that hundreds of thousands of teenagers give birth every year in the United States, little is known about the psychological impact it has on these girls. Although giving birth can be a stressor at any age, teenagers often lack social support and resources for coping. Adverse psychological consequences can have a profoundly negative impact on both the mother's level of health and that of her infant. Purpose of study. The purpose of this study was to assess for post-traumatic stress and postpartum depression, so PTS and PPD, in teenage mothers. Methods. For this pilot initial study, 28 teenage mothers were interviewed by telephone 9 months after childbirth. They were between the ages of 15 and 19 and included 13 Latina, 8 African American, and 6 Caucasian. The participants were asked to rate their perception of childbirth, respond to questions assessing PTS, and respond to questions assessing PPD. Key findings. Most of the mothers rated their experience with childbirth at a midway point between awful and great. 14 of the participants were afraid of losing control during labor, and 13 believed that they would die in childbirth. Scores from a third of the participants indicated PTS as the result of childbirth experiences. Scores from more than half of the participants indicated the presence of mild to severe depression. Implications for nursing practice. Some teenage mothers are vulnerable to PTS and PPD because of lack of social support, low self-esteem, chaotic, harsh upbringing, and family conflict. Carefully assessing the patient's history for risk factors can be the first step in minimizing these vulnerabilities. Educational programs in which girls are provided with information related to the process of labor and delivery, pain management methods, and what to expect postpartum can reduce fear and possibly reduce psychiatric complications. Psychiatric mental health nurses care for adolescent girls who have been abused or sexually assaulted, have eating disorders, or abuse alcohol and drugs. Understanding the additional stress childbirth may bring about should be considered when assessing and intervening with teenagers who have given birth. Collaboration between maternal child health nurses and psychiatric mental health nurses could provide the ideal support for pregnant teenagers and teenagers who have given birth. Behavioral theories suggest that anxiety is a learned response to specific environmental stimuli, classical conditioning. An example of classical conditioning is a boy who experiences anxiety when his abusive mother enters the room and then generalizes this anxiety as a response to all women. The social learning model suggests that anxiety is learned through the modeling of parents or peers. For example, a mother who is fearful of thunder and lightning and hides in closets during storms may transmit her anxiety to her children, who continue to adopt her behavior into adult life. Such individuals can unlearn this behavior by observing others who react normally to a storm by lighting candles and telling stories. Cognitive theorists believe that anxiety disorders are caused by distortions in an individual's thoughts and perceptions, because individuals with such distortions may believe that any mistake will have catastrophic results. They experience acute anxiety. Cultural considerations. Reliable data on the incidence of anxiety disorders are sparse, but sociocultural variation in symptoms of anxiety disorders has been noted. In some cultures, individuals express anxiety through somatic symptoms, whereas in other cultures, cognitive symptoms predominate. Panic attacks in Latin Americans and Northern Europeans often involve sensations of choking, smothering, numbness, or tingling, as well as fear of dying. In other cultural groups, panic attacks involve fear of magic or witchcraft. Social phobias in Japanese and Korean cultures may relate to beliefs that individuals' blushing, eye contact, or body odor is offensive to others. The DSM notes cultural aspects of each psychiatric disorder to alert the clinician to cultural context that must be considered before making a psychiatric diagnosis. The Considering Culture box discusses factors relevant to one anxiety disorder, ataque de nervios, primarily experienced by people from Hispanic cultures. Also review Chapter 6 for more discussion of cultural issues. Application of the nursing process. Assessment. General assessment. People with anxiety disorders rarely need hospitalization unless they are suicidal or have compulsions that cause injury, cutting self, hanging, or banging a body part. Most patients prone to anxiety disorders are encountered incidentally in a variety of community settings. A common example is someone taken to an emergency department to rule out a heart attack when in fact the individual is experiencing a panic attack. It is essential to determine whether the anxiety is secondary to another source, medical condition or substance, or the primary problem as an anxiety disorder. As previously described, the main symptoms of anxiety disorders are panic attacks, excessive anxiety, severe reactions to stress or trauma, phobias, obsessions, and compulsions. The Hamilton Rating Scale for Anxiety is a popular tool in measuring anxiety, Table 12.9. High scores may indicate GAD or PD, although it is important to note that high anxiety scores may also be a symptom of major depressive disorder. See how you rate on this tool. Keep in mind that although the Hamilton Rating Scale highlights important areas in the assessment of anxiety, it is intended for use by experienced clinicians as a guide for planning care and not as a method of self-diagnosis. Considering culture. Ataque de nervios. It goes without saying that technology and the commonplace of travel have resulted in a smaller world. Psychiatric or mental health nurses in the United States will be exposed to culture-bound syndromes with which they are unfamiliar. One example of a culture-bound syndrome is that of ataque de nervios. Ataque de nervios, or in English, attack of the nerves. This is a disorder found primarily among Hispanic populations in response to stressful events such as a death, acute family discord, or witnessing an accident. Symptoms are dramatic in people afflicted by ataque de nervios exhibit sudden trembling, faintness, palpitations, out-of-control shouting, heat that moves from chest to head, and seizure-like activities. After the episode, the affected individual often has little memory of it. This disorder is more common in socially disadvantaged females with less than a high school education. What do these symptoms sound like to you? Although there is no category for this illness in the DSM, some clinicians, researchers, and researchers believe that it is closely related to an anxiety disorder and could even be a form of panic attack. However, unlike people who have panic attacks, people with this disorder are responding to a precipitating event, and they do not typically experience fear or apprehension prior to the attack. Self-assessment. As a nurse working with an individual with an anxiety disorder, you may experience uncomfortable personal reactions. You may have feelings of frustration or anger while working with a patient with anxiety disorder, especially if it seems like that their symptoms are a matter of choice or under personal control. The rituals of the patient with OCD may hinder your ability to accomplish certain nursing tasks within the usual time. Communication with such patients can be difficult since patients with OCD often correct and clarify repeatedly as though they cannot let go of any topic. Using therapeutic communication techniques, e.g. reflecting and paraphrasing, see Chapter 10, may be ineffective. The patient may repeat the material and angrily imply that you have not understood. Patience, the ability to provide clear structure, and empathy are assets when working with patients with anxiety disorder. A person with a phobia may acknowledge that the fear is exaggerated and unrealistic, yet continues to practice avoidant behavior which may bewilder the nurse. Behavioral change is often accomplished slowly. The process of recovering is very difficult from that seen in a patient with an infection who might be given antibiotics and demonstrates improvement in 24 hours. Nurses tend to become impatient with the patient experiencing anxiety and may feel angry when more rapid progress is not made. Negative feelings are easily transmitted to the patient, who then feels increasingly anxious. The nurse who feels anger or frustration may withdraw from the patient emotionally and physically. As a result, the patient feels increasingly anxious and also withdraws. Staging outcomes in small, attainable steps can help prevent you from feeling overwhelmed by the patient's slow progress and help the patient gain a sense of control. Table 12.9. Hamilton Rating Scale for Anxiety. Excuse me. The symptom inventory provides scaled information that classifies anxiety behaviors and assists the clinician in targeting behaviors and achieving outcome measures. Provide a rating for each indicator based on the following scale: 0, none, 1, mild, 2, moderate, 3, disabling, 4, severely grossly disabling. 1. Anxious mood, symptoms, worry, anticipation of the worst, fearful anticipation, irritability. 2. Tension, feelings of tension, fatigability. Startle response, move to tears easily, trembling, feelings of restlessness, inability to relax. 3. Fear, fearful of dark, strangers, being left alone, animals, traffic, crowds. 4. Insomnia, difficulty in falling asleep, broken sleep, unsatisfied sleep, and fatigue on waking dreams. Nightmares, night terrors. Intellectual cognitive manifestations, difficulty concentration, poor memory, depressed mood swings, loss of interest, lack of pleasure in hobbies, depression, early waking, diurnal. Somatic sensory symptoms, tinnitus, blurring of vision, hot and cold flushes, feelings of weakness, picking, sensation. Somatic muscular symptoms, pains and aches, twitching, stiffness, myoclonic jerks, grinding of teeth, unsteady voice, increased muscular tone. Cardiovascular symptoms, tachycardia, palpitations, skipped beats, pain in chest, throbbing of vessels, fainting feelings. Respiratory symptoms, pressure of constriction in chest, choking feelings, sighing, dyspnea. Gastrointestinal symptoms, difficulty in swallowing, flatulence, difficulty in swallowing, flatulence, abdominal pain, burning sensations, abdominal fullness, nausea, vomiting, borgemy, not sure what that is, looseness of bowels, loss of weight, constipation. It was B-O-R, borborygmy. Genitourinary system, frequency of micturition, urgency of micturition, amenorrhea, menorrhagia, development of frigidity, premature ejaculation, loss of libido, impotence. Autonomic symptoms: dry mouth, flushing, pallor, tendency to sweat, giddiness, tension, headache, raising of hair. Behavior at interview: fidgeting, restlessness or pacing, tremor of hands, furrowed brow, strained face, sighing or rapid respiration, facial pallor, swallowing, belching, brisk tendon jerks, dilated pupils, exophthalmos. Scoring: 14 to 17 mild anxiety, 18 to 24 moderate anxiety, 25 to 30 severe anxiety. At the very least, you are likely to experience increased tension and fatigue from mental strain when working with patients experiencing anxiety. Unlike the patient who needs a dressing changed several times a week, the patient with anxiety requires emotional bandaging much more often. By having a clear understanding of the emotional pitfalls of working with patients who have anxiety disorders, a nurse is better prepared to minimize and avoid the guilt associated with strong negative feelings. By examining personal feelings, you can better understand their origin and respond objectively and constructively. Assessment guidelines: anxiety disorders. 1. Ensure that a sound physical and neurological examination is performed to help determine whether the anxiety is primary or secondary to another psychiatric disorder, medical condition, or substance abuse. 2. Determine current level of anxiety, mild, moderate, severe, or panic. 3. Assess for potential or self-harm and suicide. People suffering from high levels of intractable anxiety may become desperate and attempt suicide. Perform a psychosocial assessment. Always ask the person, what is going on in your life that may be contributing to your anxiety? The patient may identify a problem that should be addressed by counseling, like stressful marriage, recent loss, a stressful job, or school situation. 5. Note: culture can affect how anxiety is manifested. Diagnosis. The North American Nursing and Diagnostic Association, NANDA, provides many nursing diagnoses that can be considered for patients experiencing anxiety and anxiety disorders. The related to component will vary with the individual patient. Table 1210 identifies potential nursing diagnoses for the patient experiencing anxiety. Signs and symptoms that might be found on assessment and support the diagnoses the diagnoses are included. Outcomes identification. The Nursing Outcomes Classification, NOC, identifies desired outcomes for patients with anxiety or anxiety-related disorders. Each outcome contains a definition and rating scale to measure the severity of the symptom or frequency of the desired response. This rating scale enables you to evaluate outcomes in the nursing care plan. Some of the NOC recommended outcomes related to anxiety include anxiety self-control, anxiety level, stress level, coping, social interaction skills, and symptom control. Refer to Table 1211 for examples of intermediate and short-term indicators related to NOC outcomes. Potential diagnoses for anxiety disorders. Signs and symptoms. Concern that a panic attack will occur. Nursing diagnosis: anxiety, moderate, severe panic. Exposure to phobic object or situation. Signs and symptoms: presence of obsessive thoughts, recurrent memories of traumatic event, Fear of panic attacks. High levels of anxiety that interfere with ability to work, disrupt relationships, and change ability to interact with others. This has to do with ineffective coping, deficient diversional activity, social isolation. Avoidance behaviors, phobia, agoraphobia, hypervigilance after a traumatic event, ineffective role performance, inordinate time taken for obsession and compulsion, difficulty with concentration. This would be disturbed thought processes, preoccupation with obsessive thoughts, also disorganization associated with exposure to phobic object, intrusive thoughts and memories of traumatic event. That'd be post-trauma syndrome. Excessive use of reason and logic associated with overcautiousness and fear of making a mistake. That's called decisional conflict. Disruption in sleep related to intrusive thoughts, worrying, replaying, or a traumatic event. Hypervigilance, fear. It's related to insomnia, sleep deprivation, fatigue, feelings of hopelessness, inability to control one's life, low self-esteem, inability to have some control in one's life. It's hopelessness, chronic low self-esteem, spiritual distress, self-care deficit, inability to perform self-care, also related to rituals. Skin excoriation, related to rituals of excessive washing or excessive picking at the skin. That's impaired skin integrity. Inability to eat because of constant ritual performance. That's imbalanced nutrition, less than body requirements. Feeling of anxiety or excessive worrying that overrides appetite and need to eat. Also imbalanced nutrition. Excessive overeating to appease intense worrying or high anxiety levels. Imbalanced nutrition, more than body requirements. Okay. Planning. Anxiety disorders are encountered in all health settings, care settings. Nurses care for people with concurrent anxiety disorders in medical surgical units as well as in homes, day programs, and clinics. Usually, patients with anxiety disorders do not require admission to inpatient psychiatric units, and planning for their care may involve selecting interventions that can be implemented in a community setting. Whenever possible, the patient should be encouraged to participate actively in planning. By sharing decision-making with the patient, you can increase the likelihood that positive outcomes will be attained. Shared planning is especially appropriate for someone with mild or moderate anxiety. When experiencing severe levels of anxiety, a patient may be unable to participate in planning, and the nurse may be required to take a more directive role. Table 1211, knock outcomes for anxiety disorders. I'm going to skip this. You can read it. Implementation. Excuse me. When working with patients with anxiety disorders, you must first determine what level of anxiety they are experiencing. A general framework for anxiety interventions can then be built on a solid foundation of understanding. Mild to moderate levels of anxiety. A person experiencing a mild to moderate level of anxiety is still able to solve problems. However, the ability to concentrate decreases as anxiety increases. A patient can be helped to focus and solve problems when you use specific nursing communication techniques, such as asking open-ended questions, giving broad openings, and exploring and seeking clarification. Closing off topics of communication and bringing up irrelevant topics can increase a person's anxiety, making the nurse, not the patient, feel better. Reduce the patient's anxiety level and preventing escalation to more distressing levels can be aided by providing a calm presence, recognizing the anxious person's distress, and being willing to listen. Evaluation of effective past coping mechanisms is also useful. Often you can help the patient consider alternatives to problem situations and offer activities that may temporarily relieve feelings of inner tension. Table 1212 identifies interventions useful in assisting people experiencing mild to moderate levels of anxiety. 1212, interventions for mild to moderate levels of anxiety. Nursing diagnosis. Anxiety, moderate, related to situational event or psychological stress, as evidenced by increase in vital signs, moderate discomfort, narrowing of perceptual field, and selective inattention. Intervention. Help the patient identify anxiety. Are you comfortable right now? Rationale. It is important to validate observations with the patient. Name the anxiety and start to work with the patient to lower anxiety. Intervention. Anticipate anxiety-provoking situations. Rationale. Escalation of anxiety to more disorganization. Escalation of anxiety to a more disorganizing level is prevented. Intervention. Use nonverbal language to demonstrate interest, e.g., lean forward, maintain eye contact, nod your head. Rationale. Verbal and nonverbal messages should be consistent. The presence of an interested person provides a stabilizing force. Intervention. Encourage the patient to talk about his or her feelings and concerns. Rationale. When concerns are stated aloud, problems can be discussed and feelings of isolation decreased. Intervention. Avoid closing off avenues of communication that are important for the patient. Focus on the patient's concerns. When staff anxiety increases, changing the topic or offering advice is common, but leaves the person isolated. Intervention. Ask questions to clarify what is being said. I'm not sure what you mean. Give me an example. Rationale. Increased anxiety results in scattering of thoughts. Clarifying helps the patient identify thoughts and feelings. Intervention. Help the patient identify thoughts or feelings before the onset of anxiety. What were you thinking right before you started to feel anxious? The patient is assisted in identifying thoughts and feelings, and problem solving is facilitated. Intervention. Encourage problem solving with the patient. Encouraging patients to explore alternatives increases sense of control and decreases anxiety. Intervention. Assist in developing alternative solutions to a problem through role play or modeling behavior. The patient is encouraged to try out alternative behaviors and solutions. Explore behaviors that have worked to relieve anxiety in the past. Rationale. The patient is encouraged to mobilize successful coping mechanisms and strengths. Intervention. Provide outlets for working off excess energy, e.g., walking, playing ping pong, dancing, exercising. Physical activity can provide relief of built-up tension, increase muscle tone, and increase endorphin levels. Note, patients experiencing mild to moderate anxiety levels can problem solve. Severe to panic levels of anxiety. A person experiencing a severe to panic level of anxiety is unable to solve problems and may have a poor grasp of what is happening in the environment. Unproductive relief behaviors may take over, and the person may not be in control of his or her actions. Extreme regression and running about aimlessly are behavioral manifestations of a person's intense psychic pain. Appropriate nursing interventions are to provide for the safety of the patient and others and to meet physical needs, e.g., fluids and rest, to prevent exhaustion. Anxiety reduction measures may take the form of removing the person to a quiet environment with minimal stimulation and providing gross motor activities to drain some of the tension. The use of medications may have to be considered, but both medications and restraints should be used only after other more personal and less restrictive interventions have failed to decrease anxiety to safer levels. Although a patient's communication may be scattered and disjointed, feeling understood can decrease the overwhelming sense of isolation and reduce anxiety. Because individuals experiencing severe to panic levels of anxiety are unable to solve problems, the techniques suggested for communicating with persons with mild to moderate levels of anxiety may not be effective at more severe levels. Patients experiencing severe to panic anxiety levels are out of control, so they need to know they are safe. from their own impulses. Firm, short, and simple statements are useful, reinforcing commonalities in the environment and pointing out reality when there are distortions can also be useful interventions for severely anxious persons. Table 1213 suggests some basic nursing interventions for patients with severe to panic levels of anxiety. Anxiety management and reduction are primary concerns when working with patients who have anxiety disorders, but they may have a variety of other needs. When developing a plan of care, the psychiatric mental health nurse can utilize the psychiatric mental health nursing scope and standards of practice. The Nursing Interventions Classification, NIC, offers pertinent interventions in the behavioral and safety domains. Refer to Box 12.1 for potential nursing interventions for patients experiencing anxiety. Box 12.1 NIC Interventions for Anxiety Disorders. Coping Enhancement Definition: assisting a patient to adapt to perceived stressors, changes, or threats that interfere with meeting life demands and roles. Activities: provide an atmosphere of acceptance, encourage verbalization of feelings, perceptions, and fears, acknowledge the patient's spiritual cultural background, discourage decision-making when the patient is under severe stress. Hope, inspiration, definition: enhancing the belief in one's capacity to initiate and sustain actions. Activities: assist the patient to identify areas of hope in life. Demonstrate hope by recognizing the patient's intrinsic worth and viewing the patient's illness as only one facet of the individual. Avoid masking the truth. Help the patient expand spiritual self. Self-esteem enhancement. Definition: assisting a patient to increase his or her own personal judgment or self-worth. Activities: make positive statements about the patient. Monitor frequency of self-negating verbalizations. Explore previous achievements. Explore reasons for self-criticism or guilt. Relaxation therapy. Definition: use of techniques to encourage and elicit relaxation for the purpose of decreasing undesirable signs and symptoms such as pain, muscle tension, or anxiety. Activities: demonstrate and practice the relaxation technique with the patient. Provide written information about preparing and engaging in relaxation techniques. Anticipate the need for the use of relaxation. Evaluate and document the response to relaxation therapy. And this is a partial list. Okay. Table 1213, interventions for severe to panic level of anxiety. Nursing diagnosis: anxiety, severe panic, related to severe threat, biochemical, environmental, psychosocial, as evidenced by verbal or physical acting out, extreme immobility, sense of impending doom, inability to differentiate reality, possible hallucinations or delusions, and inability to problem solve. Intervention: maintain a calm manner. Rationale: anxiety is communicated interpersonally. The quiet calm of the nurse can serve to calm the patient. The presence of anxiety can escalate anxiety in the patient. Intervention: always remain with the person experiencing an acute, severe to panic level of anxiety. Rationale: alone with immense anxiety, a person feels abandoned. A caring face may be the patient's only contact with reality when confusion becomes overwhelming. Intervention: minimize environmental stimuli, move to a quieter setting, and stay with the patient. Use clear and simple statements. Rationale: helps minimize further escalation of patient's anxiety. A person experiencing a severe to panic level of anxiety has difficulty concentrating and processing information. Use clear and simple statements in repetition. Use a low-pitched voice. Speak slowly. A high-pitched voice can convey anxiety. Low-pitched can decrease anxiety. Reinforce reality if distortions occur, e.g., see objects that are not there or hearing voices when no one is present. Listen for themes in communication. Rationale for reinforced reality of distortions is anxiety can be reduced by focusing on and validating what is going on in the environment And then listen for themes in communication. In severe to panic levels of anxiety, verbal communication themes may be the only indication of the patient's thoughts or feelings. Intervention. Attend to physical and safety needs when necessary, e.g. need of warmth, fluids, elimination, pain relief, family. Rationale. High levels of anxiety may obscure the patient's awareness of physical needs. Intervention. Because safety is an overall goal, physical limits may need to be set. Speak in a firm, authoritative voice. You may not hit anyone here. That's what you say. You may not hit anyone here. If you can't control yourself, we will help you. Rationale. A person who is out of control is often terrorized. Staff must offer the patient and others protection from destructive and self-destructive impulses. Provide opportunities for exercise, e.g. walk with nurse, punching bag, ping pong game. Physical activity helps channel and dissipate tension and may temporarily lower anxiety. When a person is constantly intervention. When a person is constantly moving or pacing, offer high-calorie fluids. Dehydration and exhaustion must be prevented. Intervention. Assess need for medication or seclusion after other interventions have been tried and not been successful. Rationale. Exhaustion and physical harm to self and others must be prevented. Guidelines for basic nursing interventions are: identify community resources that can offer the patient specialized treatment proven to be highly effective for people with a variety of anxiety disorders. 2. Identify community support groups for people with specific anxiety disorders and their families. 3. Use counseling, milieu therapy, promotion of self-care activities, and psychobiological and health teaching interventions as appropriate. Counseling. Basic level psychiatric mental health nurses use counseling to reduce anxiety, enhance coping and communication skills, and intervene in crisis. When patients request or prefer to use integrative therapies, the nurse performs assessment and teaching as appropriate. Milieu therapy. As mentioned earlier, most patients who demonstrate anxiety disorders can be treated successfully as outpatients. Hospital admission is necessary only if severe anxiety or symptoms interfere with the individual's health or if the individual is suicidal. When hospitalization is necessary, the following features of the therapeutic milieu can be especially helpful to the patient. Structuring the daily routine to offer physical safety and predictability, thus reducing anxiety over the unknown. Provide activities to promote sharing and cooperation. Provide therapeutic interactions, including one-on-one nursing care and behavior contracts, including the patient in decisions about his or her own care. Promotion of self-care activities. Patients with anxiety disorders are usually able to meet their own basic physical needs. Self-care activities that are most likely to be affected are discussed in the following sections. Nutrition and fluid intake. Patients who engage in ritualistic behaviors may be too involved with their rituals to take time to eat and drink. Some phobic patients may be so afraid of germs they cannot eat. In general, nutritious diets with snacks should be provided. Adequate intake should be firmly encouraged, but a power struggle should be avoided. Weighing patients frequently, e.g. 3 times a week, is useful in assessing nutrition. Personal hygiene and grooming. Some patients, especially those with OCD and phobias, may be excessively neat and engage in time-consuming rituals associated with bathing and dressing. Hygiene, dressing, and grooming may take several hours. Maintenance of skin integrity may become a problem when the rituals involve excessive washing and skin becomes excoriated and infected. Some patients are indecisive about bathing or about other clothing or what clothing should be worn. For the latter, limiting choices to 2 outfits is helpful. In the event of severe indecisiveness, simply presenting the patient with the clothing to be worn may be necessary. You may also need to remain with the patient to give simple directions. Put on your shirt. Now put on your slacks. Matter of fact, support is effective in assisting patients to independently perform as much of a task as possible. Encourage patients to express thoughts and feelings about self-care. This communication can provide a basis for later health teaching or for ongoing dialogue about the patient's abilities. Elimination. Patients with OCD may be so involved with the performance of rituals that they may suppress the urge to void and defecate. Constipation and urinary tract infections may result. Interventions may include creating a regular schedule for taking the patient to the bathroom. Sleep. Patients experiencing anxiety frequently have difficulty sleeping. Patients may perform rituals to the exclusion of resting and sleeping, and physical exhaustion may occur. Patients with GAD, PTSD, and acute stress disorder often experience sleep disturbances from nightmares. Teaching them how to discover ways to promote sleep, e.g. warm bath, warm milk, relaxing music, and monitoring sleep through a sleep record are useful interventions. Chapter 20 offers an in-depth discussion of sleep disturbances. Pharmacological interventions. Several classes of medications have been found to be effective in the treatment of anxiety disorders. Table 1214 identifies medications approved by the U.S. Food and Drug Administration for the treatment of anxiety, as well as medications that do not have specific approval but are commonly used off-label for anxiety disorders. Review Chapter 3 for more detailed explanations of the actions of psychotropic medications. Which we did that. Excuse me. Antidepressants. Selective serotonin reuptake inhibitors are the first-line treatment for acute stress disorder and PTSD. They are preferable to tricyclic antidepressants, TCAs, because they have more rapid onset of action and fewer problematic side effects. Table 1214, drug treatment of patients with anxiety disorders. Antidepressants, SSRIs, Celexa, used for panic disorder, social anxiety disorder, OCD, generalized anxiety disorder, post-traumatic stress disorder. Lexapro, generalized anxiety disorder. That's the FDA approved one. The other ones I said were off-label. Most of them are off-label. So yeah, off-label for Lexapro would be panic disorder, social anxiety disorder, obsessive compulsive disorder, PTSD. Fluoxetine or Prozac, FDA approved, are panic disorder and OCD. Off-label are SAD, GAD, PTSD. Fluvoxamine or Luvox, FDA approved, are OCD and SAD, and off-label are PD, GAD, and PTSD. Paroxetine or Paxil, that's, you got the FDA approved ones are PD, SAD, OCD, GAD, PTSD, and doesn't look like any off-label for Paxil. Sertraline or Zoloft, FDA approved, panic disorder, SAD, OCD, PTSD, and off-label is GAD. Selective serotonin norepinephrine reuptake inhibitors. Cymbalta, FDA approved, panic disorder and GAD, off-label OCD, PTSD, and OCD. No, PTSD. That's it. Effexor is the approved is GAD, SAD, and PD, and off-label is OCD and PSTD. Tricyclics, Elavil, nothing is approved by the FDA, but off-label is PD, GAD, and PTSD. And clomipramine or anafranil, approved is OCD, and off-label is PD, GAD, PTSD. And then norepinephrine is there's nothing approved, but off-label is panic disorder, GAD, PTSD. Doxepin or adipin sinequan is nothing proved, but PD, GAD, PTSD for off-label, Tofranil, all off-label, PD, GAD, PTSD, Aventil, Pamelor, all off-label, PD, GAD, PTSD. Alright, monoamine oxidase inhibitors, MOA, is that right? Well, Nardil, nothing approved, but it's PD. It's all the same. Oh, there's no way you have to memorize all this. That's just ridiculous. Basically, it's just a bunch of. It goes through all the SSRIs and SNRIs, and then it goes into some benzos or non-benzos, buspirone. Some antihistamines are all used for off-label. Nothing's really approved. Beta blockers, anticonvulsants, all used off-label for GAD, PD, SAD, PTSD, OCD. Oh, yeah, OCD. Anti-anxiety drugs, also called anxiolytics, are often used to treat the somatic and psychological symptoms of anxiety disorders. When moderate or severe anxiety is reduced, patients are better able to participate in treatment of their underlying problems. Benzodiazepines are most commonly used because they have a quick onset of action. However, due to the potential for dependence, these medications ideally should be used for short periods only until other medications or treatments reduce symptoms. An important nursing intervention is to monitor for side effects of benzodiazepines, including sedation, ataxia, and decreased cognitive function. Benzodiazepines are not recommended for patients with a known substance abuse problem and should not be given to women during pregnancy or breastfeeding. Box 12.2 gives important information for patient teaching. 12.2 Patient and Family Teaching Anti-Anxiety Medications. 1. Caution the patient not not to increase dose or frequency of ingestion without prior approval of therapist. That these medications reduce ability to handle mechanical equipment. Not to drink alcoholic beverages or take other anti-anxiety drugs because depressant effects of both would be potentiated. Avoid drinking beverages containing caffeine because they decrease the desired effects of the drug. 2. Recommend that the patient taking benzodiazepines avoid becoming pregnant because these drugs increase the risk of congenital anomalies. 3. Advise the patient not to breastfeed because these drugs are excreted in the milk and would have adverse effects on the infant. 4. Teach a patient who is taking monoamine oxidase inhibitors about the details of tyramine restricted diet. 5. Teach the patient that cessation of benzodiazepine use after 3 to 4 months of daily use may cause withdrawal symptoms such as insomnia, irritability, nervousness, dry mouth, tremors, convulsion, and confusion. Medications should be taken with or shortly after meals or snacks to reduce gastrointestinal discomfort. Drug interactions can occur and acids may delay absorption. Cimetidine interferes with metabolism of benzodiazepines, causing increased sedation. Central nervous system depressants such as alcohol and barbiturates cause increased sedation. Serum phenytoin concentrations may build up because of decreased metabolism. Buspirone. Okay. Other classes of medications. Other classes of medications sometimes used to treat anxiety disorders include beta blockers, antihistamines, and anticonvulsants. These agents are often added if the first course of treatment is ineffective. B blockers block the nerves that stimulate the heart to beat faster and have been used to treat SAD. Anticonvulsants have shown some benefit in the management of GAD, PD, PTSD, and SAD. Antihistamines are a safe, non-addictive alternative to benzodiazepines to lower anxiety levels and, again, are helpful in treating patients with substance use problems. Another therapeutic strategy may come in a most unusual form. D-cycloserine is an antibiotic used to treat tuberculosis, but has also been demonstrated to enhance learning. D-cycloserine binds with N-methyl D-aspartate and NMDA receptors in the area of the brain that mediates fears and phobic responses. The amygdala and may help patients the amygdala and may help patients unlearn fear responses more quickly. Administration of this drug while undergoing cognitive behavioral therapy actually promotes fear extinction, not just fear conditioning, in phobic individuals. It has also been useful when combined with extinction-based exposure therapy in the treatment of obsessive compulsive disorder and social anxiety disorder. Integrative theory. Chapter 36 identifies a number of complementary practices of integrative therapy. Chapter 36 identifies a number of complementary practices of integrative therapies that people use to cope with stress in their lives. Herbal and complementary therapy is very popular, and an estimated $34 billion is spent in the United States annually for these products. However, herbs and dietary supplements are not subject to the same rigorous testing as prescription medications. Also, herbs and dietary supplements are not required to be uniform and there is no guaranteed bioequivalence of the active compound among preparations. Problems that can occur with the use of psychotropic herbs include toxic side effects and herb-drug interactions. Nurses and other healthcare providers do well to improve their knowledge of these products so that discussion with their patients provide informed and reliable information. The integrative therapy box discusses kava kava, an herb often used for its sedative and anti-anxiety effects. Health teaching. Health teaching is a significant nursing intervention for patients with anxiety disorders. Patients may conceal symptoms for years before seeking treatment and often come to the attention of healthcare providers during a co-occurring problem. People with PD and GAD seem more motivated than those with other anxiety disorders to get treatment. Most seek help during the first year of symptoms. Only 7% of people with PTSD seek help during the first year of symptoms. In fact, on average, they wait 12 years before getting help for their symptoms. Teaching about specific disorder and available effective treatments is a major step in improving the quality of life for those with anxiety disorders. Whether in a community or hospital setting, nurses can teach patients about signs and symptoms of anxiety disorders, presumed causes or risk factors, especially substance abuse, medications, the use of relaxation techniques, and the benefits of psychotherapy. Integrative therapy. Kava kava. Kava kava is prepared from a South Pacific plant, Piper methaceticum, and is used as an herbal sedative and anti-anxiety with anti-anxiety effects. Prior to seeking psychiatric treatment, patients with anxiety disorders may try kava kava in the belief that herbs are safer than medications, but it may have a darker side. Kava kava is known to dramatically inhibit liver enzyme P450, necessary for metabolism of many medications. This inhibition could result in liver failure, especially when taken along with alcohol or other medications such as central nervous system depressants. Anti-anxiety agents fall into this category. This potentially dangerous interaction highlights the need for the nurse to ask about all medications the patient is taking, both prescribed and over-the-counter, before administering medications to those with anxiety disorders. Several countries have actually taken kava kava off the market, but some researchers believe that the benefits of this drug may outweigh the risks compared to other medications used to treat anxiety. The bottom line is that kava kava is considered to be beneficial for short-term use in mild to moderate anxiety, but as with any drug, it should be used carefully. Advanced practice nurses use several cognitive and behavioral treatment approaches, including relaxation, training, modeling, systematic desensitization, response prevention, and thought stopping. Cognitive therapy. Cognitive therapy is based on the belief that patients make errors in thinking that lead to mistaken negative beliefs about self and others. For example, I have to be perfect for my boyfriend, or my boyfriend will not love me. Through a process called cognitive restructuring, the therapist helps the patient 1. Identify automatic negative beliefs that cause anxiety. 2. Explore the basis for these thoughts. 3. Reevaluate the situation realistically. And 4. Replace negative self-talk with supportive ideas. Behavioral therapy. There are currently several forms of behavioral therapy, which involve teaching and physical practice of activities to decrease anxious or avoidant behavior. Relaxation training. Relaxation exercises for breathing or muscle groups are taught. The relaxation response is the opposite of the stress response and results in a reduced heart rate and breathing and relaxed muscles. Refer to Chapter 11 for a description of different approaches to relaxation training. Modeling. The therapist or significant other acts as a role model to demonstrate appropriate behavior in a feared situation, and then the patient imitates it. For example, the role model rides in an elevator with a claustrophobic patient. Systematic desensitization. The patient is gradually introduced to a feared object or experience through a series of steps, from the least frightening to the most frightening, graduated exposure. The patient is taught to use a relaxation technique at each step when anxiety becomes overwhelming. For example, a patient with agoraphobia would start with opening the door to the house to go out on the steps and advance to attending a movie in a theater. The therapist may start with imagined situations in the office before moving on to in vivo or live exposures. Flooding. Unlike systematic desensitization, this method exposes the patient to a large amount of an undesirable stimulus in an effort to extinguish the anxiety response. The patient learns through prolonged exposure that survival is possible and that anxiety diminishes spontaneously. For example, an obsessive patient who usually touches objects with a paper towel may be forced to touch objects with a bare hand for 1 hour. By the end of that period, the anxiety level is lower. Response prevention. This method is used for compulsive behavior. The therapist does not allow the patient to perform compulsive ritual hand washing and e.g. hand washing, and the patient learns that anxiety does subside even when the ritual is not completed. After trying this in the office, the patient learns to set time limits at home to gradually lengthen the time between rituals until the urge fades away. Thought stopping. In this technique, a negative thought or obsession is interrupted. The patient may be instructed to say "stop" out loud when the idea comes to mind, or to snap a rubber band worn on the wrist. This distraction briefly blocks the automatic undesirable thought and cues the patient to select an alternative, more positive idea. After learning the exercise, the patient gives the command silently. Cognitive behavioral therapy. Cognitive behavioral therapy combines cognitive therapy with specific behavioral therapies to reduce the anxiety response. Cognitive behavioral therapy includes cognitive restructuring, psychoeducation, breathing, restraining, and muscle relaxation, teaching of self-monitoring for panic and other symptoms, and in vivo or real-life exposure to feared objects or situations. Evaluation. Identified outcomes serve as the basis for evaluation. Each knock outcome has a built-in rating scale that helps the nurse measure improvement. In general, evaluation of outcomes for patients with anxiety disorders deals with questions such as the following. Is the patient experiencing a reduced level of anxiety? Does the patient recognize symptoms as anxiety related? Does the patient continue to display obsessions, compulsions, phobias, worrying, or other symptoms of anxiety disorders? If present, are they more or less frequent or less intense? Is the patient able to see newly learned behaviors to manage anxiety? Can the patient adequately perform self-care activities? Can the patient maintain satisfying interpersonal relationships? Can the patient assume usual roles? Key points to remember. Anxiety has an unknown or unrecognized source, whereas fear is a reaction to a specific threat. Peplau operationally defined 4 levels of anxiety: mild, moderate, severe, and panic. The patient's perceptual field, ability to learn, and physical and other characteristics are different at each level. The defenses against anxiety can be adaptive or maladaptive, and in a hierarchy from healthy to intermediate to immature. Table 12.2 provides adaptive and maladaptive examples of many of the more common defense mechanisms. 12.1 Case study in nursing care plans, severe level of anxiety. The following case study describes a man experiencing a severe level of acute anxiety. See if you can match his signs and symptoms with those in 12.1. Matt Michaels, a 63-year-old man, comes into the emergency department. I'm going to skip this. No, I'm going to read it. Okay. Matt Michaels, a 63-year-old man, comes into the emergency department with his wife, Ann, who has taken an overdose of sleeping pills and antidepressant medications. 10 years earlier, Ann's mother died, and since that time, Ann has suffered several episodes of severe depression with suicide attempts. She has needed hospitalization during these episodes. Ann Michaels had been released from the hospital 2 weeks earlier after treatment for depression and threatened suicide. Matt has a long-established routine of giving his wife her antidepressant medication in the morning and her sleeping medication at night, and keeping the bottles hidden when he is not at home. Today he had forgotten to hide the medication before he went to work. His wife had taken the remaining pills from both bottles with large quantities of alcohol. When Matt returned home for lunch, Ann was comatose. In the ED, Ann suffers cardiac arrest and is taken to the intensive care unit. Matt appears very jittery. He moves about the room aimlessly. He drops his hat, a medication card, and his keys. His hands are trembling, and he looks around the room, bewildered. He appears unable to focus on any one thing. He says over and over in a loud, high-pitched voice, "Why didn't I hide the bottles?" He is wringing his hands and begins stomping his feet, saying, "It's all my fault. Everything is falling apart." Other people in the waiting room appear distracted and alarmed by his behavior. Matt seems to be oblivious to his surroundings. Assessment. Gabriel Brown, the psychiatric nurse clinician working in the ED, comes into the waiting room and assesses Matt's behavior as indicative of a severe anxiety level. After talking with Matt briefly, Gabriel believes nursing intervention is indicated. Gabriel bases his conclusion on the following assessment of the patient. Objective data. Unable to focus on anything. Engaging in purposeless activity, walking around aimlessly. Oblivious to his surroundings. showing unproductive relief behavior, stomping, wringing hands, dropping things. Subjective data. Everything is falling apart. Why didn't I hide the bottles? It's all my fault. Diagnosis. Gabriel formulates the following nursing diagnosis. Anxiety, severe, related to the patient's perception of responsibility for his wife's coma and possible death, as evidenced by inability to focus, confusion, and the feeling that everything is falling apart. Outcomes identification. Patient will demonstrate effective coping strategies. Planning. Gabriel thinks that if he can lower Matt's anxiety to a moderate level, he can work with Matt to get a clear picture of his situation and place the events in a more realistic perspective. He also thinks Matt needs to talk to someone and share some of his pain and confusion to help sort out his feelings. Gabriel identifies 2 short-term goals. 1. Patient's anxiety will decrease from severe to moderate by 4 p.m. Patient will verbalize his feelings and a need for assistance by 4 p.m. Implementation. Gabriel takes Matt to a quiet room in the back of the ED. He introduces himself to Matt and comments that he notices that Matt is upset. He says, "I will stay with you." At first, Matt finds it difficult to sit down and continues pacing around the room. Gabriel sits quietly and calmly while listening to Matt's self-recriminations. He attends carefully to what Matt is saying and what he is not saying, to identify themes. After a while, Matt becomes calmer and is able to sit next to Gabriel. Gabriel offers him orange juice, which he accepts and holds tightly. Gabriel speaks calmly, using simple, clear statements. He uses communication tools that are helpful to Matt in sorting out his feelings and naming them. Dialogue. Matt: Yes, I forgot to hide the bottles. She usually tells me when she feels bad. Why didn't she tell me? Nurse: You think that if she had told you she wanted to kill herself, you would have hidden the pills? Gabriel, the therapeutic tool here is Gabriel asks for clarification on Matt's thinking. Matt: Yes, if I had only known, this wouldn't have happened. Nurse: Sounds as if you believe you should have known what your wife was thinking without her telling you. The therapeutic communication technique is here Gabriel clarifies Matt's expectations that he should be able to read his wife's mind. Matt: Well, yes, when you put it that way. I just don't know what I'll do if she dies. When Gabriel thinks that Matt has discussed his feelings of guilt sufficiently, he asks Matt to clarify his thinking about his wife's behavior. Matt is able to place his feelings of guilt in a more realistic perspective. Next, Gabriel brings up another issue, the question of whether Matt's wife will live or die. You said that if your wife dies, you don't know what you will do. Here, Gabriel reflects Matt's feelings back to him. Matt: Oh, God, he begins to cry. I can't live without her. She's all I have in the world. Silence. Nurse: She means a great deal to you. Well, again, reflecting Matt's feelings back to him. Matt: Everything since her mother died. We are each other's only family. Nurse: What would it mean to you if your wife died? Gabriel asks Matt to evaluate his feelings about his wife. Matt: I couldn't live by myself alone. I couldn't stand it. He starts to cry again. Nurse: It sounds as if being alone is very frightening to you. Gabriel's restating in clear terms Matt's experience and feelings. Matt: Yes, I don't know how I manage by myself. Nurse: A change like that could take time to adjust to. Gabriel validates that if Matt's wife died, it would be very painful. At the same time, he implies hope that Matt could work through the death in time. Matt: Yes, it would be very hard. Again, Gabriel gives Matt a chance to sort out his feelings and fears. Gabriel helps him focus on the reality that his wife may die and encourages him to express fears related to her possible death. After a while, Gabriel offers to go up to the ICU with Matt to see how his wife is doing. When they arrive at the ICU, although Anne is still comatose, her condition has stabilized and she is breathing on her own. After his arrival at the ICU, Matt starts to worry about whether he remembered to lock the door at home. Gabriel suggests that he call neighbors and ask them to check the door. This time, Matt is able to focus on everyday things. Gabriel makes arrangements to see Matt the next day when he comes in to visit his wife. The next day, Anne has regained consciousness. She is discharged 1 week later. At the time of discharge, Matt and Ann Michaels are considering family therapy with the psychiatric nurse clinician once a week in the outpatient department. Evaluation. The first short-term goal is to lower anxiety from severe to moderate. Gabriel can see that Matt has become more visibly calm. His trembling, wringing of hands, and stomping of feet have ceased, and he is able to focus his thoughts and feelings with Gabriel's help. The second short-term goal established for Matt is that he will verbalize his feelings and his need for assistance. Matt is able to identify and discuss with Gabriel his feelings of guilt and fear of being left alone in the world if his wife should die. Both these feelings are overwhelming him. He is also able to state that he needs assistance in coping with his feelings in order to make tentative plans for the future. 12.2 Case Study and Nursing Care Plan Post-Traumatic Stress Disorder. Mr. Blake, 46, is brought to the emergency department by his very distraught wife after she finds him writing a suicide note and planning to shoot himself in the woods with a handgun. Mr. Blake is subdued, shows minimal affect, and his breath has the distinct odor of alcohol. When asked about suicidal thoughts, he states that he is worthless and that his wife and family would be better off if he were dead. He refuses to contract for safety. The decision is made to hospitalize him to protect him from danger to himself. Mr. Blake's wife gives further history. Her husband is a construction contractor who served in the United States National Guard during the Iraq War. He lost half his squad from a roadside bombing, narrowly escaping with his life. He walks with a permanent limp due to the attack. Upon returning home, he showed no signs of anxiety and refused offers of crisis treatment, stating, "I was in a war. I can handle stress." But 6 months later, Mrs. Blake noticed her husband had trouble sleeping. His mood was irritable or withdrawn. He avoided news reports on television, and he started drinking daily. He complained of nightmares, but would not talk to her about his fears. He only agreed to go to the primary care provider, a nurse practitioner, to request sleeping medication. Mr. Blake was admitted to the psychiatric unit and his care assigned to Mrs. Dawson, a registered nurse. She observes that Mr. Blake is quiet and passive as he is oriented to the unit, but that he looks around vigilantly and is easily startled by sounds on the unit. Assessment. Self-assessment. Mrs. Dawson is a registered nurse with an associate degree and 3 years of experience on this unit. Initially, she feels sympathy for Mr. Blake, and he reminds her of her Uncle James, who served in Vietnam. She is concerned because his suicide plan was lethal, and he is guarded in his speech, not revealing his thoughts or feelings. She realizes that as she implements suicide precautions, she must demonstrate an attitude of hope and acceptance to encourage him to develop trust. Also, she must stay neutral and not convey any pity or sympathy. Objective data: sleep difficulty, nightmares, hypervigilance, alcohol use, irritability, withdrawn mood, constricted, reduced range of affect, feels estranged from wife and children, avoidance of news coverage with potential for emergency reports, refusal of a treatment and safety contract, plan for suicide. Subjective data: I don't deserve to live. I should have died with the others. You can't stop me. Diagnosis: risk for suicide related to anger and hopelessness due to severe trauma, as evidenced by suicidal plan and verbalization of intent. Lethal plan with saved prescription medication and alcohol. Refusal to contract for safety, emotional withdrawal from wife. Outcomes identification: patient will consistently refrain from attempting suicide. Planning: the initial plan is to maintain safety for Mr. Blake while encouraging him to express feelings and recognize that his situation is not hopeless. Implementation: Mr. Blake's plan of care is personalized as follows. Short-term goal: patient will speak to staff whenever experiencing self-destructive thoughts. The intervention here: administer medications with mouth checks. Rationale: address risk of hiding medications. Evaluation: goal met. After 8 hours, patient contracts for safety. Every shift and starts to discuss feelings of self-harm. Intervention also provide ongoing surveillance of patient and environment. This provides one-to-one monitoring for safety. Also contract for no self-harm for specified periods. This encourages increased self-control. Also use direct, non-judgmental approach in discussing suicide. Shows acceptance of a patient's situation with respect. Also provide illness teaching regarding PTSD. Offers reality of treatment. Second goal, patient will express feelings by the third day of hospitalization. Interventions here are interact with patient at regular intervals to convey caring and openness and to provide an opportunity to talk. This encourages development of trust. Goal met by second day, patient occasionally answers questions about feelings and admits to anger and grief. Okay, well, also interventions for patient will express feelings at the end of third day is use silence and listening to encourage expression of feelings. Shows positive expectation that patient will respond. Be open to expressions of loneliness and powerlessness. Allows patient to voice these uncomfortable feelings. Share observations or thoughts about patient's behavior or response. This directs attention to here and now treatment situation. Third goal, patient will express will to live by discharge from unit. Interventions listen to expressions of grief. This supports patient communicates that such feelings are natural. Also encourage patient to identify own strengths and abilities. This affirms patient's worth and potential to survive. Also explore with patient previous methods of dealing with life problems. Reinforces patient's past coping skills and ability to problem solve now. Assist in identifying available support systems. Addresses fact that anxiety has narrowed patient's perspective, distorting reality about loved ones. Refer to spiritual advisor of individual's choice. This allows opportunity to explore spiritual values and self-worth. Evaluation. See individual outcomes and evaluation within the care plan. So anxiety disorders are the most common psychiatric disorder in the United States and frequently co-occur with depression or substance abuse. Research has identified genetic and biological factors in the etiology of anxiety disorders. Psychological theories and cultural influences are also pertinent to the understanding of anxiety disorders. Patients with anxiety disorders suffer from panic attacks, irrational fears, excessive worrying, uncontrollable rituals, or severe reactions to stress. People with anxiety disorders are often too embarrassed or ashamed to seek psychiatric help. Instead, they may go to primary care providers with multiple somatic complaints. Psychiatric treatment is effective for anxiety disorders. Basic level nursing interventions include counseling, milieu therapy, promotion of self-care activities, psychobiological intervention, and health teaching. Advanced practice nursing interventions include behavioral and cognitive behavioral therapies. And that is chapter 12 of Varcoralos, Anxiety and Anxiety Disorders.